All right. Good afternoon, everyone. Welcome to the CDPH and CMA Virtual Grand Rounds. I'm Dr. Rita Nguyen. I'm pinch hitting today for Dr. Kim Newell, who's out of the country, and I'll be moderating today's session on the Southern California wildfire response and what clinicians need to know. I really want to thank you all for your interest in this topic, and just want to acknowledge all the loss, human suffering that our Southern California communities have been facing for the earlier part of this year. As you all know, it's been unprecedented losses of property, structures, and lives with tremendous impact on individuals, physicians, the healthcare delivery system. We pulled this session together relatively quickly, recognizing the timeliness of it for many of you who are directly impacted, but we also recognize in the face of climate change. Oh, I hope folks can hear me. It looked like I was disconnected briefly, but in the face of climate change, and you are probably sensing this yourselves personally, more and more severe weather changes, more devastating wildfires. So even if you and your patients are not directly impacted now, we're hoping that this content is helpful for you should it occur in your community going forward. And certainly we know a lot of patients move and they may be asking questions on their long-term impact. So hoping that this can be of direct use to you all. Today, we're going to be joined by experts from both the California Department of Public Health and the California Department of Managed Healthcare to present on the health impacts of urban fire, recovery efforts, impacts to healthcare access, including pharmacy, as well as provider flexibility on health plan requirements during this disaster. In general, the goal of the series with CMA and CDPH is to bring to the forefront public health issues that are seen throughout the state and with just-in-time education. CME is being offered for this. You will be sent a survey after the completion of the webinar where you can attest to attendance, and upon completion of the survey, you will be sent out your certificates. I think we went by it, but none of our speakers have relevant disclosures for today. And with that, I'm going to welcome our first speaker, Dr. Cyrus Rangan. As always, we're going to try to protect a lot of time for Q&A. So Dr. Cyrus Rangan graduated from the Medical College of Pennsylvania in 1995. He's Assistant Deputy Director at the Center for Healthy Communities at the California Department of Public Health. He oversees the State Childhood Lead Poisoning Prevention Branch, Occupational Health Branch, Environmental Health Investigations Branch, and the Emergency Preparedness Team. He also serves as the Assistant Medical Director with the California Poison Control System. He's an attending physician and medical toxicologist at Children's Hospital of Los Angeles, providing bedside consultations and clinical education. And with that, I'm going to hand it off to Cyrus.
Thank you very much, Dr. Nguyen. So let's just go ahead and get right into it. Next slide, please. Okay, so we're going to talk about wildfire smoke in California. We'll talk about some general concepts and, of course, some specific concepts that are affecting us right now as these fires are getting under control and as we deal with the aftermath. Next slide, please. Just to reiterate, I have no relevant disclosures for today. Next slide. So just as to outline what we're going to be talking about today, first we'll talk about a little bit of background about wildfire trends and patterns in California, and then we'll talk about the air quality impacts of wildfire smoke and the composition of that smoke and the kinds of things we need to be worried about within that composition. We'll talk a little bit about the wildland-urban interface, the WUI. We'll get to that a little bit later. And then we'll spend a little bit more time talking about the health effects of wildfire smoke and the disproportionate impacts that we may expect amongst subpopulations in our affected areas. And we'll have a little bit of time to talk about some mitigation strategies, some of which you can actually point your patients to as well, mitigation strategies that they can use sometimes during fire events and even after them as well. And we'll touch on some CDPH programs and activities related to wildfire smoke and public health. Next slide, please. Okay, so just as a matter of background, When you look at the acres per year that have been burned by wildfires in California, as I think we're all aware, it's been increasing quite rapidly over the past several years. And you can see on the graph on the right there, you look at the 2020s and the stark difference that you see between that and the early 1990s, for example. The graph below that, you can see that low severity fires, moderate severity fires, and high severity fires have been increasing quite significantly over the past several years too. These data, I unfortunately only go through 2022, so it doesn't include the fires that we're currently experiencing right now in Southern California and actually all across California. But the numbers are considerably worse when you add all of those in. So when you look at wildfires in California, they've been increasing in frequency, severity, and duration, and it's a major emerging problem that we don't really have a great solution for. Next slide, please. When you think about air quality and how air quality is affected, what's kind of interesting, if you look at the graph in the upper right, we've actually been noticing since 2000 a gradual downtrend in the average level of particulate matter 2.5, which is the particulate matter that's 2.5 microns or less. This gradual decrease has been seen as a result of ways that we've been controlling vehicle emissions and all kinds of other sources of particulate matter. And that's been a great environmental success story in California when you look from 2000 to around 2015. But then since then, we've had a lot more wildfires, and we're starting to see some of the gains that we've seen from that improved air quality being erased because of the higher contribution that wildfires are making towards our PM 2.5 levels, and actually all particulate level matters in California. The number of smoke days has increased in the western U.S. all over the state. You look at that graph or that pictograph in the middle, and you'll see that any region has experienced significantly more smoke days than they have in the past. And so wildfires now account for the lion's share of all the PM 2.5 exposures that we do see here in California. Next slide. When you look at the composition of wildfire smoke, it can be pretty complicated, but this is just hitting the highlights here. Obviously, I mentioned particulate matter. There's coarse particles, which are PM10s, which means particulate matter that's 10 microns or lower. And then a subset of that is the PM 2.5s, which is everything 2.5 microns and lower. So that includes ash and soot, and also organic matter. There's also another subset of ultra fine particles, and these are particles that are 0.1 microns or lower. Now, when you get down to 0.1 microns, they're still particles, but they sort of behave like gases, which means these are the kinds of particles that once they hit the alveolar interface, they can actually be absorbed into our system and cause more problems systemically. Not only that, they can actually be absorbed right through the olfactory nerve, through the cribriform plate, and all the way to the brain without having to go through the lungs. So we know that that can happen as well. Now, we have a lot of animal studies that kind of support how ultrafines may affect health. When we do that, cardiovascular health and neurotoxicity, all of these have definitely been seen in animals. The extent to which ultrafine particles affect humans is still something that's under study. And so we're in the baby stages of that kind of research at the moment. But we do know that there is a significant role that ultrafines play. It's just a matter of how much and to what extent, though that's still being researched. And then, of course, is your primary gaseous pollutants like carbon dioxide, carbon monoxide, nitrogen oxides, formaldehyde, benzene as well, volatile organic compounds, and metals that especially get stirred up from soil as wildfires are raging on. And a lot of things can affect the composition and the concentrations of all of these components based on the type of vegetation and the moisture level of the actual vegetation that's being burned, whether it's flaming, whether it's smoldering, and the soil composition as well. So I'll just kind of leave it right there because that's another hour-long discussion that we could go on. But just realize that smoke composition is quite variable depending on these factors. Next slide, please. So I talked a little bit about in the beginning about the wildland-urban interface, WUI. What does that mean? Well, basically that means houses that are built very, very close to wild areas that are prone to catching on fire. And in California, we have a lot of this up and down the state. California has the greatest number of houses overall compared to any other state in these wildland-urban interfaces. So that means when we have wildfires, we have more people that are affected in their homes because they're so close by. In fact, we now have 5 million housing units, and that's almost half of California's total housing that are in these wildland-urban interface zones, and this number, unfortunately, is ever growing. When we think about structural fires that result from wildfires, the composition of the smoke can change a little bit. You're going to get a little bit more volatile organic carbons and solvent burning and PVC pipe burning and things like that that contribute to other factors to that smoke composition. One interesting thing that does arise from structural fires is cyanide. As you burn PVC and plastics, cyanide levels actually increase quite significantly. Now, that doesn't really affect people in the outdoor arena quite as much, but when people succumb in a house fire, cyanide poisoning is actually one of the largest contributory reasons, not just the carbon monoxide that we've always been led to believe causes asphyxiation, but the cyanide actually may lead to more rapid deaths in homes when people die in house fires than we used to realize. Next slide, please. So when we think about the health effects of wildfire smoke, again, this could be another 1-hour lecture, so I'm just going to give you the broad strokes here. The PM 2.5s is where most of the money is in terms of determining what kinds of health effects that people will have. All of the other things that I mentioned, all of those gases, the metals, etc., they do play a role, but not as significant as the PM 2.5s, which are responsible for the lion's share of the health effects that you'll see in patients who are exposed to wildfire smoke. So in particular, PM 2.5, because they have the capacity to reach your alveoli. So from the acute exposure standpoint, it's all the common sense stuff. The eye irritation, sore throat, throat irritation, wheezing, coughing, chest pain, all that's very, very common in all patient populations. Whether you have chronic disease, whether you're a baby, whether you're a senior, it really doesn't matter. All of these things can be seen in varying degrees of severity. When we think about the health outcomes associated with wildfire smoke, this has been researched for quite a while by folks at the EPA, the CDC, the American Lung Association, and we found that, yeah, all-cause mortality is increased as a result of wildfire smoke exposure, morbidity, asthma exacerbations, COPD, cardiovascular events, etc. Pregnancy and birth outcomes. We've seen adverse data in these arenas as well. Hypertensive disorders during pregnancy, preterm birth, low birth weight. Cognitive impairment. Now, the cognitive impairment is both direct and indirect, but we do see that it definitely is a very important variable that does change with wildfire exposure. And mental health, as a result of all of these problems, is affected quite significantly as well. As you can see with the pictograph on the right there, most of the reason that PM 2.5s will cause these kinds of problems is rather indirect. It's a lot of inflammation and oxidative stress that results from the PM 2.5 exposure that we initially breathe in. So decades ago, we used to think it was really only a lung issue, but we now know that lots of other systems in the body can be affected because of these indirect phenomena such as inflammation and oxidative stress that can then lead to, as you can see in this pictograph, cardiovascular effects. But we now know that there's probably some neurotoxic effects and some others as well that are really just, again, in the baby stages of research. Next slide, please. So this is just to give you a little bit of an overview about the kinds of things that you might expect to see in patients who are exposed to wildfire smoke, whether they were exposed while their own home was on fire and they had to evacuate, or if they just happened to be in an evacuation zone that was impacted by smoke. Now, I divided this up into infectious disease, toxic contaminants, and some physical injuries as well. And why infectious disease? It's not that the fire, of course, carries infectious disease and infects people, but the result of evacuation and the result of the effect on households from wildfire smokes, from power outages, those kinds of things, these can affect a number of factors that then can lead to increased infectious diseases. So you look under GI, for example, damaged food because of power outages, mass feeding at shelters. There may be unsafe food handling or unsafe food storage, donated food, food prepared at home that ends up at these shelters as well. And you never know what may be in those foods. So you may be seeing patients who have cases of exposure to infectious agents that cause food poisoning. Food prep with contaminated water, because water may not necessarily be pristine during fire events as well. contaminated drinking water itself, especially for people who have private wells. Let's suppose you have someone who has a private well, their chlorination system gets shut down or damaged as a result of the fire, they may now have contaminated drinking water. Sewage leaks, especially for people who have septic tanks in rural areas, and then vector-borne diseases as well. So all of these factors come into play as a result of people being in environments where there's impact from fire or smoke. But then more directly, you look at the toxic contaminants for GI illnesses. Fire-damaged food itself could be directly toxic to the GI tract. We talked about the drinking water as well. You can have direct toxins that result in drinking water systems, VOCs from burnt pipes, external contaminants, etc. When you look on the dermal side of things, of course, again, you have people who are all clustered together in shelters. You can have infectious agents being passed around there. But from the toxic contaminant standpoint, wildfire smoke itself can actually cause skin dryness and irritation, and also exposure to corrosives as people try to do cleanup around their homes, and we have corrosive material that's in the debris on the ground. People may have dermal effects from that. The respiratory standpoint, again, mostly the common sense kinds of things. But again, from the indirect standpoint, when people go to shelters because of the overcrowding and you've got vulnerable populations, you may have people who already have certain diseases as they are being sheltered in these areas and may pass them to others. So there may be an increase in respiratory diseases as a result of that. But more directly from the contaminants, air pollutants and wildfire smoke, particularly PM2.5s, are going to be responsible for a lot of the respiratory illnesses that you see. Next slide, please. Just to extend a little bit more here, I talked a little bit about cardiovascular issues on a previous slide, air pollutants and wildfire smoke, particularly the PM2.5s, indirectly through inflammation and oxidative stress can cause cardiovascular stress, and that can be particularly harmful for people who already have chronic disease. Cancer. Now, this is a question we get all the time about increased risk of cancer. We do know on a very broad level that people who are exposed to extensive wildfire smoke may be at increased risk of respiratory, sinus, nasal cancers in the future. The degree to which they are going to have an increased risk, we still don't know the answers to these questions. And again, everyone's exposure is going to be a little bit different. So it's a very, very difficult thing to study. But we do know in an overall sense that yes, the potential for increased risk of lung cancer or other respiratory sinopulmonary cancers is going to be higher for individuals who are exposed to wildfire smoke extensively. There are also some other constituents like asbestos that we know can cause mesothelioma, a very special kind of cancer of the lining of our lungs and abdomen. Now, when it comes to wildfires, we know that asbestos gets liberated, especially when a lot of older homes get burned up. But we actually have not seen much in terms of increased risk of actual asbestosis or mesothelioma being a major problem in wildfire situations. So even though we do see asbestos get liberated, we do see it in debris, it does need to be removed under containment, we haven't seen that end result of really significant increases of asbestos-related diseases. Now, again, that excludes people who do a lot of work in this area, firefighters, etc. But as far as the general population goes, you don't generally expect those. Pregnancy, I touched on a little bit as well, miscarriages, low birth weights, preterm births. And then one special consideration that we are talking about even to this day right now at CDPH is lead exposure. Well, a lot of older homes, of course, still have a lot of lead in them, and that lead can get liberated as a result of wildfires. And we do know that our state air quality management district, who did air monitoring during the active blazes, they did notice in that January 7th to January 10th time period that there were elevated levels of lead in the air. Now, those did come down, and they came back down to regional typical levels. But then we do worry a little bit about the dispersion of that lead and where it's going to land, and the soil that may be in and around homes that may be affected by that increased lead in the air. So we are actually talking even right now about what to do about that situation and trying to work with our partner agencies to make a determination about how far that lead may have spread and what kind of testing may need to be done in those kinds of areas, and even what we should be doing about children in those areas who maybe they've already undergone lead testing as a regular screening at age 1 and 2, but now they've been exposed to these fires, and it may be useful for to do repeat blood lead testing in children who were very, very close to these fires. So more on that later as we make further determinations and recommendations, but keep that in mind on all of your radars. Next question. Or next slide. Thank you. And just to kind of wrap up the physiological and mental health impacts, mental health and other impacts also play a big role here. And again, a lot of it is a little bit more indirect, a little bit more remote from the fire itself. But community mental health definitely is affected quite severely due to the physical health impacts, loss of property and community, evacuations that occurred. Sometimes places of work and worship are also affected by these fires, and people don't have those places to go to. That can affect community mental health too. Responder mental health is another thing that we are focusing on quite significantly. All of our fire departments are very highly aware of this issue about responders, not only who may have mental health issues just in general from fighting these fires for long hours and days, but many of whom actually live in the impacted areas and may be dealing with that as they are first responders at the same time. And that can be particularly taxing for them. Another indirect thing that we like to put on people's radars is that, you know, you have people who may be regular users of medications or illicit drugs. And unfortunately, we do see that in abandoned homes, some people will go to those abandoned homes and look for things like illicit drugs and other substances and use those. And that can, you know, contribute to their problems. In addition, people have firearms in their homes, and a lot of these abandoned homes, people do unfortunately go to these homes and search for those firearms. And again, that means more firearms are out there as well that shouldn't be there. So these again are kind of a little bit more remote and a little more indirect, but they are things that we do think about when we think about the overall impacts of smoke exposure and fire exposure. On the right, there's just a number of resources you can go to that touch on a lot of these issues that I've just talked about here. All of these links are clickable in this presentation. Next slide, please. So as you can imagine, there's going to be some disproportionate impacts, as there would be from any kind of environmental disaster. And the sensitive populations are, again, the common sense ones. So our babies, our senior populations, our pregnant patients, and then our patients with respiratory disease or other chronic disease. These are the populations that are going to be affected the most from wildfire smoke inhalation. And then there's a number of socioeconomic factors that come into play as well. So your lower income communities, communities of color, indigenous communities that may not necessarily have optimal healthcare access or access to medications. These communities, I think we all know, are going to be more highly affected by these fires and smoke inhalation than other communities. Next slide. I'd like to point out some Los Angeles County resources. Our colleagues at Los Angeles County have been posting a lot of very useful information on their websites. I think if I don't have the exact link in my head here, but if you just simply Google recovery fires LA County, you'll get to all these documents that I'm talking about here. A couple in particular that I'd like to draw your attention to. If you have patients who have questions about replacing or accessing medications, of course they can come to you about that as their care providers, but they have a little system here where they can get some answers to these questions and get refills for their medications from local pharmacies a little bit more quickly and a little bit more readily. So there's a lot of great resources and links on these pages that you'll find on the LA County's recovery website. Next slide. Patients who are concerned about health insurance, especially if they don't have any health insurance during this time, California residents can enroll in health coverage through Covered California until January 31, 2025, and I think they're going to be extending that. So there's a lot of resources there and numbers that people can call and links they can click on as well if you have patients who are facing health insurance coverage problems. Next slide, please. More Los Angeles County resources. Again, these are all housed in the same recovery website that LA County has put up. There are some LA County resources for schools. That's a clickable link there on the left for when you get this presentation yourselves. And again, a number of flyers and resources that not only schools can use, but even us as clinicians can kind of use to kind of guide our patients as they are returning to school and to give them the precautions that they need in order to make sure that they're going to be comfortable when they do return to school. Next slide, please. And here's a link about cleanup after fire. There's a lot of resources out there for this, and Los Angeles County's resources is one of the best places to start on this. And one thing that your patients may be coming to you about is it safe for me to go ahead and start cleaning up my home after a fire has taken place, even if their home has not been directly damaged by fire itself? What about the smoke impacts? And excuse me, what about the ash impacts and the soot impacts and things that I might not be able to see? Well, this is a little bit of a judgment game. So, for people who are very far away and live in the South Bay of Los Angeles, well, there's really nothing for them to do. But for people who are much closer to fires, who again didn't sustain fire damage but may have had smoke damage or ash deposition in and around their homes, then it may be worthwhile to do a deep clean of their homes. Now, people should not really take it upon themselves to do deep cleaning of their own homes. There's a lot of protocols that need to be followed and a lot of protection that needs to be followed in order to make sure that people don't harm themselves during the cleaning process. But by and large, you want to make sure that patients are aware that they shouldn't be dry sweeping anything. They shouldn't be using air blowing machines or vacuum machines that just simply vacuum up dry materials, because you'll disperse those into the air and potentially cause more problems for yourself in and around your home. So wet mopping and similar kinds of practices are what are recommended in these settings to make sure that you're not going to be exposing yourself anymore. Bottom line, people should always have professionals do deep cleaning. They really shouldn't try to do it themselves. But if there's minor cleaning that people are going to be doing, this with wet rags and wet mops, then it's reasonable to have people wear N95 masks at least to make sure that they're filtering out harmful particles as they are cleaning in and around their homes for minor kinds of cleanup. Next slide, please. So a little information on mitigation here. When you look on the public health standpoint, there's actually clean air centers that we have up and down California that get activated during wildfires. And so for people who, especially for those with chronic disease, and they need to go to a place where they can breathe, very well filtered air, there are a few places in Los Angeles where that can happen. There's in that graphic on the right there, it looks like there's only one diamond in the Los Angeles area. If you zoom in on that, there's actually, I think, 3 or 4 diamonds. There's one in the Pacoima area. There's a couple on Beverly Boulevard, a couple in Sepulveda Boulevard. So those are the kinds of areas where we have these. Unfortunately, some of these clean air centers can be affected by the fires themselves, and we may need to shut them down and put them somewhere else. But these were developed by our California Air Resources Board in order to provide people with a place that they can go to breathe filtered air temporarily while a fire might be going on. As for homes, it's always good to recommend that people use MERV 13 or higher rated filters during smoke events to prevent smoke from contaminating their own household airspace. So MERV 13 is about the minimum that you need to make sure that you keep PM 2.5s under control. And of course, just standard air conditioning and portable air cleaners are always reasonable as well. They may not necessarily do the job for the entire home, but they're certainly better than nothing. And then sometimes creating a clean air room or clean air space in your home can be useful as well. So one particular room where you've got, all the windows and doors sealed with duct tape and foam and things like that, and an air purifier in that room. So it can be at least a temporary sort of sanctuary that people in the house can go to if they need to get some relief from some of the smoke that's going on in the outdoor air spaces. And then weather stripping, phone taping windows and doors in general is a reasonable thing to recommend to patients and families as well. In general, as long as as long as people are staying indoors, that's probably the number one thing that people can do to ensure that they're going to be reducing their exposure to smoke overall and reducing their general activity. And then N95 respirators, yes, those are great, but realize that those tend to be the least effective of all of these measures. So just because you have an N95, don't consider yourself fully protected from the dangers of wildfire smoke. Next slide. And in terms of mitigation, I just wanted to point people to this as well. I won't spend a ton of time on this, but you can actually build your own DIY air filter with a box fan. It's called the Corsi Rosenthal box, and it essentially means taking 4 MERV 13 filters, and you can actually build this with duct tape and a 20-inch box fan and putting it on the top. And there's lots of instructions. I've included them here as well, and that patients can actually build these themselves. It's very, very cheap to do so, and you can actually then have your own essentially particulate air purifying machine at home without having to go to the expense of ordering one yourself or getting one from somewhere else. So these have actually been shown to be quite efficacious if done properly with enough duct tape. Next slide. And I just wanted to point out one CDPH a project that is underway. I think it actually ended in 2024. It's from 2021 to 2024, called the Fresca Project. So filtration for respiratory exposure to wildfire smoke from swamp cooler air. And what this is doing is actually looking more at our agricultural communities where people are outdoors for extended periods of time and then potentially exposed to wildfire smoke. And so we are essentially equipping swamp coolers with filters in these homes. And then what we're doing is doing urine and saliva measurements of various chemical, various chemicals and biomarkers, and trying to see if we can actually reduce exposure to these kinds of constituents that are in wildfire smoke as a result of having these kinds of mechanisms in people's homes. And we're so far looking at some pretty positive data from that. And there's more to come as we do a quality assessment on that data and publish more about it in the coming year. I just want to kind of alert people to this program. Next slide, please. So that brings me basically to the end of my presentation. These are just some resources as well that people can look at, general resources about some of our efforts behind wildfires and management. Next slide. This is merely continuation of the same. Next slide. And just briefly, I'd like to acknowledge a few folks, particularly Andrew Rosenberg, Lori Copan of our CDPH Environmental Health Investigations Branch, and Sauda Yarabadi and Mark Starr of our CDPH Center for Environmental Health, who all contributed content to this presentation, and Jeff Wagner as well from our Environmental Health Laboratory Branch. And very special acknowledgement to our colleagues down in Los Angeles County Department of Public Health, who have been really working tirelessly to try to mitigate everything that's been going on, not only during the fires, but in this fire aftermath, and to try to restore LA County to some sense of normalcy. So a big shout out to them as well. Thank you very much. That concludes my portion of the presentation. Dr. Nguyen, turn it back to you.
Thank you so much, Dr. Rangan. That was really helpful. We'll have an opportunity for Q&A afterwards. As I was listening to you, I also recognized the framing here is that Los Angeles County actually accounts for 1/4 of the state's population. And so whether or not you were directly impacted by the fires and the burn scar, the region was impacted by smoke and even just the psychological trauma of what occurred. So although I recognize many of you probably do not live in the Southern California region, again, the context of more fires and climate change, also just recognizing 1/4 of our state lives in this region. With that, I'm going to hand it over to our next speaker, Dan Southard, who is the Chief Deputy Director at the Department of Managed Healthcare, which provides the regulatory oversight for the vast majority of managed healthcare plans in California, along with DHCS, which administers Medi-Cal. So Dan reports directly to the Director of DMHC. He has served in a variety of roles at DMHC, including multiple managerial roles at the Help Center. Prior to his appointment to the Chief Deputy Director, Dan was the Deputy Director for the Office of Plan Monitoring, where he is responsible for evaluating and promoting health plan regulatory compliance related to quality improvement, utilization management, and member grievances, and ensuring health plan networks have the right types of providers necessary to deliver healthcare services that meet time and geographic access requirements. So with that, I'm going to hand it over to Dan.
Thank you, Dr. Nguyen. Next slide, please. Thank you. As Dr. Nguyen noted, my name is Dan Southard. I'm the Chief Deputy Director of the Department of Managed Healthcare. And before I get into what the DMHC did to respond to the Southern California wildfires, I just want to provide a quick overview of the DMHC in general in case you're not aware. Next slide, please. So what is the DMHC? Let's go to the next slide, please. So the DMHC, or Department of Managed Healthcare, is the licensor and regulator of full service and specialized health plans. The DMHC regulates 96% of the state regulated business in California. We share the regulatory oversight with the California Department of Insurance. The California Department of Insurance has approximately 1 million lives under their jurisdiction, where we have close to 30 million lives under our jurisdiction. We license and regulate all HMOs and some PPO and EPO products. The California Department of Insurance takes over the rest of the PPO and EPO regulation. We also regulate some large group and most small group and individual products. Most Medi-Cal managed care plans. There are county operated health systems or codes plans that are not under the jurisdiction of the DMHC. And we also license and regulate specialized health plans, including dental, Delta Dental, Vision, VSP, behavioral health, chiropractic, and prescription drug plans. And we license Medicare Advantage plans, but strictly for financial solvency only. And for the purpose of this presentation, I think the most helpful division within the Department of Managed Healthcare is our Help Center, where consumers, whether they're under our jurisdiction or not, can come to our Help Center for assistance or advice or information on where they can go to the right jurisdictional agency for assistance. Next slide, please. So SB 979 from 2022 amended Health and Safety Code 1368.7, which requires health plans to file notifications with the DMHC within 48 hours of a stated or proclaimed state of emergency. Next slide, please. And Health and Safety Code 1368.7 requires the health plans to notify the DMHC, and those notifications must describe whether the health plan has or expects to have a disruption in its operation as a result of the emergency, how the health plan is communicating with potentially impacted members, and action the health plan has or will take to ensure their members' healthcare needs are met. Next slide, please. So the state of emergency was declared on January 7th, 2025. On January 9th, 2025, the DMHC issued an all-plan letter. Next slide, please. And the DMHC's all-plan letter directed health plans to ensure that the members have access to medically necessary care, including medically necessary prescription drugs, ensure the health plan has a toll-free number for members or providers to call for answers to questions regarding the loss of ID cards, prescription refills, how to replace durable medical equipment that was destroyed, and how to access healthcare services. They are also required to prominently display on their website information describing how impacted members can continue to access healthcare services and how members and providers can contact the plan for more information. Next slide, please. We also directed through our all-plan letter to suspend prescription refill limitations without authorization and allow the impacted members to utilize out-of-network pharmacies at the same in-network cost sharing they would have paid if they went to an in-network pharmacy, and allow, as I noted, members to replace durable medical equipment or supplies, and also allow members to access care from out-of-network providers if in-network providers are unavailable within the timely access or geographic standards, or if the member is outside the service area due to displacement. If a member receives services from an out-of-network provider, they shall only be subject to their in-network cost sharing. I just want to talk about timely access and geographic standards. So timely access requirements are the health plan has to offer a health plan member an appointment with a provider within 48 hours if an authorization is not required for urgent issues, or within 96 hours if authorization is required. And then for non-urgent issues, it is either 10 business days or 15 business days, depending if it's a PCP appointment or a specialist appointment. So those are the timely access requirements. Geographic standards, our health plans must have a PCP or a primary care hospital within 15 miles or 30 minutes of the member's residence or work address. For specialists, it is within a reasonable distance. There isn't a specific time or distance in law currently. Next slide, please. The DMHC's All Planner also directed health plans to reduce or remove unnecessary barriers for the efficient admission, transfer, or discharge of health plan members to or from contracted or non-contracted hospitals. Next slide, please. Now, the DMHC, this goes a little differently. I've said that our All Plan letter directed all those other activities which I've described. Our All Plan letter also encouraged health plans to shorten the time frames for prior approvals, pre-certifications, referrals, and to extend the time of approvals that have already been given so that that referral remains valid for a longer period of time, and extend the health plan's claim filing deadlines as a result of the wildfires. Next slide, please. In addition to our all plan letter on January 14th, we posted a resource guide on our public website. The link will be included in the presentation. What we did is we asked all of the health plans under the DMHC's jurisdiction that operate in Ventura and Los Angeles counties to provide us with phone numbers and websites that we can include in this resource guide for providers as well as members to utilize to obtain access to prescription drugs, healthcare services, DME replacement equipment. That resource guide provides the information for you or your patients to contact the health plans for assistance. Next slide, please. So the DMHC is closely monitoring the situation, is working with the California Medical Association and the California Hospital Association. If we need to update our guidance to health plans, we'll do that as necessary. Next slide, please. And then getting help for your patients. So this is what I talked about earlier, our help center. If a health plan member needs assistance in obtaining replacement medication, equipment, or like, they should first contact their health plan for assistance. If their health plan is not helping them resolve the issue, they should contact, or the issue is an urgent issue, they should contact our help center for assistance at either dmhc.ca.gov, where we have online or online complaint forms. You can submit directly to the DMHC online. Those are available in English or Spanish, or we have our complaint and independent medical review form on our website in the 15 threshold languages, or you can call the toll-free number at 888-466-2219, and that assistance is free to everyone and is available in all languages. Next slide, please. I think we're just at questions at this point. That's it for my presentation. Back to you, Dr. Nguyen.
Thank you so much, Dan, for all that you and your team at DMHC and all of the departments within Health and Human Services are doing for so many Californians. I'll start with a question actually for you, Dan, since you're on, and it's about what is the best place to direct enrollees to alternative resources or options for out-of-network care, mental health, medication, and DME?
Yeah, I think the first contact is to the health plan, utilizing the numbers in our resource guide. If they're not getting timely assistance from their health plan, then reach out to our help center. Generally, if it's a complaint type issue, we require members to go through the plan's grievance process before availing themselves to the DMHC's processes, but in these circumstances, we would likely bypass that process.
Yeah. And a related question we got, which I think fits into this, is how can displaced patients on essential injectable medicines like insulin get supplies? It sounds like the same route. And then to Dr. Rangan's point, LA has resources specific to LA in which how the county workers can also help them, right?
Correct. And again, health plans are aware of this. They should be assisting their members to get these replacement in a very timely manner. Again, if they're not getting that assistance, direct them to our help center. We'll take care of it.
Okay, great. Thank you so much. Dr. Rangan, I'm going to direct this one to you. There's a lot of confusion about prevention of exposure to urban wildfire toxins and using the AQI. Other than check the AQI and looking for floating ash and the smell of smoke, what should community members do to stay safe? Oh, you're on mute.
There we go. So it's a great question. When it comes to AQI, we should always look at AQI as the first thing that we look at, not necessarily the be-all, end-all about our local air quality. So if your AQI is in the good or moderate range, in general, you can rest assured that your area is going to be fine. But when it's in that moderate range and kind of reaching to the high end of that moderate range, then we have a lot of question about what's going to be, okay in terms of activity, whether we let young children out for recess and lunch and all of those kinds of things. So the bottom line is this: use the AQI as an initial screen. But even if AQIs are looking reasonable and there is any kind of smell or any visible or smellable smoke or ash around, then I would let that sort of trump the AQI. In other words, don't use the AQI as saying that everything is fine, and use more of what you can actually smell yourself, because our noses tend to be better detectors of a lot of this stuff than a lot of the instrumentation out there that we have to monitor air quality. So let your nose be your guide is one way to go. All of our schools, especially those in LA Unified, are keenly aware of this issue and know that AQI is not the only way to go.